Hello, everyone. My name is Pavlos Anastasiadis from the Translational Therapeutics Research Group at the University of Maryland School of Medicine. I would like to express my warmest thanks to the Focused Ultrasound Foundation and the Cancer Research Institute for hosting yet another Focused Ultrasound and Cancer Immunotherapy workshop. I have been tasked to give an overview of the FUS Immunomodulation Consortium efforts. Within this consortium, we explored the option of a synergistic effect between FUS and immune responses in a preclinical glioma model. This is a multi-center effort that started a couple of years ago and included 6 different sites across the United States and Canada. I will take a minute or two to provide background for some colleagues who may have joined recently or who may not be acquainted with the field of brain tumor biology or immunology. Each site was asked to follow the same experimental protocol in terms of tumor implantation and downstream assays. Each one of the 6 participating centers applied a different mode of FUS to study immune responses in this glioma murine model. We're going to see in more detail these individual modalities later in the presentation. A few words to the immune environment in the setting of glioblastoma. Glioblastoma has been extensively studied as a paradigm for cancer-associated immunosuppression. Systemic immunosuppression in GBM has been demonstrated as evidenced by impaired cellular immunity in patients. Glioblastomas have a paucity of infiltrating T cells and harbor a relatively low number of somatic mutations compared with other solid tumor types. These tumors profoundly affect the immune system both locally and systemically. In addition to tissue-resident myeloid cells or microglia, evidence suggests that migrating myeloid cells have an important role in glioblastoma-associated immunosuppression. The glioblastoma microenvironment is a highly immunosuppressive environment of tumor and immune cells. The lymphoid compartment also contributes to the immunomodulating environment with regulatory T cells, in particular mediating immunosuppressive effect through upregulation of various soluble factors, immune checkpoint molecules, and metabolic pathways. Dendritic cells in the GBM tumor microenvironment can traffic via the tumor draining lymph nodes of the brain to the deep cervical lymph nodes and can present antigen to promote an adaptive anti-tumor immune response, although this process might be abrogated in the context of the systemic immunosuppression that is intrinsically associated with glioblastoma and can also be potentiated by the current standard of care treatments for this disease. For example, systemic temozolomide chemotherapy induces a lymphopenia that is exacerbated by bone marrow sequestration of T cells. A few words to the experimental protocol and the timeline. Luciferase transduced GL261 cells were stereotactically implanted in a striatum of the brain of albino female mice 6 to 10 weeks old. After cell implantation, tumor growth was monitored by bioluminescence and MRI imaging. On day 14 post-implantation, the animals were prepared for FUS treatment with one of the 6 modalities used in the consortium. Treatments were administered in principle under MR image guidance after co-registration. On day 21 post-implantation, FUS-treated and control mice were euthanized and their brains, spleens, and cervical lymph nodes harvested for use in downstream assays to assess changes in immune cell populations. These assays included flow cytometry, immunohistochemistry, and interferon gamma production. In the next slide, you are going to see the participating centers and which modality each one of these centers applied. Moving to the blood-brain barrier opening modality. For MR-guided focused ultrasound blood-brain barrier opening, mice were catheterized for intravenous injections of MRI contrast agent and microbubbles. Mice were treated with a 1.14 megahertz spherical single-element transducer within an MR-compatible FUS system after co-registration. MRI contrast agent was administered intravenously to confirm tumor location by contrast-enhanced T1-weighted MR imaging. A 4-spot grid of sonications was overlaid on the MR visible tumor, and sonications were carried out at 0.5% duty cycle for 2 minutes at 0.4 and 0.6 megapascal. Contrast-enhanced T1 weighted MR imaging was repeated to confirm blood-brain barrier opening. The combination of FUS plus microbubbles increased dendritic cells maturity in the tumor draining lymph nodes and meninges. This combination also increased antigen experienced PD1 expressing CD8 plus T cells in the tumor microenvironment and the percentage of CD8 plus T cells that were producing granzyme B in the superficial draining lymph nodes. Moving on to the microvascular ablation combined with blood-brain barrier opening and anti-PD1. Anti-PD1 antibody was administered in combination with FUS at 255 and 300 kilopascal. Although there were no effects observed at the lower FUS level, the combination of a PD1 inhibitor and FUS showed little difference to PD1 inhibitor alone for adaptive immunity. However, the combination increased activated M1 microglia and PDL1 microglia. In the spleen and cervical lymph nodes, there was an increase in T-cell immunoglobulin and ITIM domain receptor expression on CD3 plus and CD4 plus T cells, only with a combination of FUS and a checkpoint inhibitor. For thermal ablation, FUS fields were generated using a single element spherically curved air bag transducer with a diameter of 25 millimeters and confocal length of 20 millimeters driven in continuous wave. The transducer had a central opening of 4 millimeters in diameter to facilitate hydrophone insertion. The resonant frequency of the transducer was 1.06 megahertz, but it was driven at the fifth harmonic at 5.51 megahertz to allow FUS-mediated heating within the desired depth range. The glioma tumor was identified with gadolinium contrast-enhanced T1 weighted MR imaging. To achieve thermal ablation, MR-guided focused ultrasound sonications were performed at 5.51 megahertz for 15 seconds at an acoustic power level of 2.45 watts. During sonication, MR thermometry was performed to map the temperature rise in the brain at the focal depth of the transducer. Lesion formation was confirmed by assuming a conservative thermal dose threshold of 240 cumulative equivalent minutes at 43 degrees Celsius based on MR thermometry measurements. Thermal ablation led to a slow tumor growth at 21 days post-inoculation. Finally, immunohistochemistry showed no difference in the tumor of CD4 plus and CD4-8 plus T cells. For pulse-focused ultrasound, treatments were also carried under MR image guidance. The sonications were carried out at 1.5 megahertz and 2.3 megapascal. 6 to 9 spots were overlaid on the MR visible tumor, and each spot was treated for 60 seconds. Regulatory T cells were increased in the spleen, suggesting redistribution in the cell population. In the draining lymph nodes, increased in myeloid-derived suppressor cells and a decrease in CD8 plus T cells were observed. In the tumor, there were no observed differences in immune cell population 7 days post-FUS. However, immunohistochemistry of tumor tissue showed increased CD plus 4 and CD8 plus T cells. For hyperthermia, the tumors were located using T2 weighted MR imaging. Accurate targeting in vivo was confirmed by sonicating the tumor for 10 seconds and using MR temperature imaging to localize the focal heating. A binary controller based on MR temperature imaging allowed to reach the set point temperature of 41.5 Celsius within few seconds and remained at this set temperature for a duration of 12 minutes in total, at which point the treatment was concluded. FUS-induced hyperthermia caused changes in immune cell trafficking in brain tumors. There were significant increases in effector CD8 plus T cells and activated natural killer cells. There were no changes observed in immune cell populations outside the brain. For histotrypsy, an 8-element transducer operating at 1 megahertz was used. The transducer had an aperture diameter of 58.6 millimeters and a focal length of 32.5 millimeters. And an average of 1.5 cycle pulses were applied with a peak negative pressure of 40 megapascal, where for a total of 50 pulses at a single location. Histotripsy treatments led to a significant reduction in myeloid-derived suppressor cells in the tumor, and an increase in interferon gamma was observed. A few closing remarks. Immunotherapy is clearly nothing short of revolutionary in the treatment of glioblastoma. Multiple findings support the hypothesis that glioblastoma is a cold tumor. Glioblastomas are known to have relatively few tumor-infiltrating lymphocytes compared with other tumor types, suggesting that they are quiescent tumors in terms of immune reactivity. Hence, combination approaches with the aim of making these cold tumors hot and thus augmenting current immunotherapy strategies are desperately needed. The use of FUS as a local therapeutic modality to increase the availability of tumor antigens and immunotherapy to drive an anti-tumor immune response provides the rationale for this combination approach. We observed local and systemic immunologic shifts in glioma-bearing animals, including both thermal and mechanical modes. This may indicate that immunotherapeutic combinations with FUS may be synergistic, as FUS may be able to locally activate the tumor immune microenvironment to drive an anti-tumor immune response. With this, I would like to acknowledge the wonderful team that I have been fortunate to work with. In particular, I would like to acknowledge and wholeheartedly thank Kelsey Timby, Natasha Sheibani, Tyler Gerhardson, Tao Soon, Anastasia Villalopulu, and Mark Santos. I would like to thank my mentor, Dr. Whitworth, and all PIs in the consortium for their valuable support. Finally, I would like to thank again the FUS Foundation for moving the field of FUS-mediated immunomodulation forward. I thank you all very much for making time to listen to this presentation. Please reach out with questions, and please stay tuned as we're reaching the final stages of the manuscript preparation. I look forward to the next and hopefully to many more workshops in future. Thank you so very much.